Hi, my name is Abrar Waliuddin. I'm a DMT at Frankston Hospital. Just going through question 3 for the Monash Fellowship Written Exam 2024.2. So this was a question on methemoglobinemia, 57-year-old male worker. So the first question was list 4 drugs or toxins from separate classes that cause methemoglobinemia. The answer was essentially to put a nitrite or nitrate of some form. I accepted sodium nitroprusside in that as well. Any local anesthetic of these sort of types. Antibiotics, antimalarials, dapsone, which is a very popular choice, chloroquine and primaquine. And if people mention others such as raspbericase, propanil, paraquat, aniline dyes, mothballs, potassium permanganate, and copper sulfate, we accepted any of those. So that was basically just a straightforward list knowledge check. So part B was a sub-question on, apart from cyanosis and confusion, list 5 other clinical and or biochemical findings from MetHB. So the list that really was looking for, you could choose any 5 here: seizures, headache, any arrhythmias, chest pain, tachypnea, metabolic acidosis, chocolate brown discoloration of blood, elevated MetHB percentage on blood gas, and cyanosis, oxygen saturation gap, or PaO2 status mismatch. I did accept hypoxia, and a lot of people would write, for example, SATs at 85% and not responding to oxygen therapy, and that was fine as well. So this question, subsection C, for completing the table by listing 2 indications and 2 adverse effects regarding antidote treatment with methylene blue in this patient. So in this one, we really were just looking for indications with MetHB fractions greater than 20%, or MetHB fraction greater than 10%, and symptoms, or coexisting anemia, chronic lung disease, or cardiac failure. And as we all know, methylene blue is used in vasoplegic shock. Any adverse effects below, such as headache, dizziness, nausea, vomiting, chest discomfort, dyspnea, and blue staining of mucous membranes are acceptable. Hyper or hypotension, pain at site of IV administration, as well as high doses giving you methemoglobinemia, that's worsening, is acceptable as well. Serotonin toxicity may be induced in the presence of serotonergic drugs. So really, I think it was obvious that this question, people had parts of this question right, but nobody really got all 4 of them properly correct. But that's was the key for this station. So this subsection, the last one, the patient has been given methylene blue with some improvement in the clinical state but wants to discharge against medical advice. This was done universally really well. Vast majority of people scored their marks in this section. That tells me that people have practiced this repeatedly. The outline we were really looking for was to explore and address the reasons for wishing to discharge, assess capacity, explain the risks of not following advice, and offer alternative management options and safety netting, and of course, documentation. The mark breakdown for this exam, essentially the pass mark I set it at 12. That seems to be a reasonable one out of all the different subsections. The top mark in this one was scored by one candidate. It was 17. Another candidate scored 16. The lowest mark was 5. I don't think median and mean marks are of much use to candidates in preparation for exams, so I haven't calculated those for you. So the common mistakes people made were not understanding the pathophysiology behind MetHB, writing low PaO2 and low SATs, for example, together. Drug lists from the same classes repeated. Cyanide was a very popular option. Not answering for the particular patient. For example, many people mentioned pregnancy MetHB percentage as an indication, as our patient is a male. Repeating the same concept or idea in the Dharma sub-question, so writing discharge advice and safety netting in different ways, essentially. Thank you.